So I'm a nurse practitioner and a pediatric nurse practitioner. So I've been taking care of children since 1986, and specifically in otolaryngology since 2006. But I was in pediatric GI prior to that. And I will never forget my first patient with Down syndrome. We'll just call her Jay. And she was wonderful, and I took care of her on the pediatric floor. She unfortunately had HIV because she got a blood transfusion back in the 80s when she had her cardiac surgery. So she was in the hospital a lot. I think of her a lot, as well as another little girl that I took care of through my GI practice, who I still see today in my ENT practice, which is super cool. So I will dedicate my talk to those two kids because they were my favorites. All right, so we're going to talk about Down syndrome, and I have a million slides and a lot of information, so we can ask questions at the end. I also put my email in here. It's fine to email me. I can't give you specific medical advice, but it's fine to email me if you have questions. All right. I don't have any disclosures. We have some objectives, just basically discussing the ENT care of kids with Down syndrome and the things that we need to do, and some guidelines as well that are available through the American Academy of Pediatrics as well. You guys all know Down syndrome is the most common chromosomal condition that we see. It occurs in about 1 to 700 to 800 live births. 95% of the kids with or people with Down syndrome have trisomy 21, and I have a picture of that. Some historical information you guys probably all know. John Landon Down described the syndrome with the facial features and tone issues and learning disabilities, and the chromosome was identified in 1959 by Jerome Lejeune. There's a lot of comorbidities. Comorbidities, what we refer to as things that can cause problems. And they're all different types of things that you need to be aware of when you take care of kids with Down syndrome, as well as being a parent and an advocate for your child with Down syndrome. And I've listed all those. We're just going to talk about the ENT stuff today. We're going to briefly touch on the immune disorders that are really not well understood. We'll talk a little bit about ear disease and hearing loss. We'll skirt over the nasal symptoms and some of the airway issues, and we'll talk about sleep apnea, probably most importantly. The immune deficiency has always been suspected, and I know as a nurse, I always thought kids with Down syndrome always had very, very runny noses and purulent, green snot all the time. So there has been a lot of different studies and a lot of different theories on this, but there's probably something wrong with the T and B cell function, whether they're reduced or they don't function well. There may be a poor response to vaccinations. There may be something on the chromosome 21 itself that regulates the B cell response. And then there's certain pathogens that the body has difficulty fighting. Those are bugs, bacteria, viruses, that type of thing. So let's jump right into ear disease. Ear disease is divided in a couple different categories. Some are anatomic challenges, and that's with the narrow ear canals, as well as the trouble equalizing pressure in the middle ear space, which is called eustachian tube dysfunction, and fluid in the middle ear. Ear canal stenosis. You guys all know that babies with Down syndrome have very narrow ear canals. It's difficult to see through the ear canal to visualize the eardrum. The cerumen, which is a normal thing that excretes out of the cells, the hair follicles in the ear canal, gets impacted in the ears and you can't see the eardrum. That cerumen also can cause some muffling of the hearing. Ear canals typically grow by about 2 to 5 years, but just generically or generally, the ear canals tend to be smaller. So it's a little bit more of a challenge to diagnose an ear infection or to diagnose fluid in the middle ear space. Sometimes it's difficult to get specific data from the type of hearing test people are doing, especially if there's an insert into the ear canal, doing a tympanogram or a DPOAE. Sometimes it's difficult if the ear canal is very narrow. Eustachian tube dysfunction is probably one of the biggest things we see, and that's trouble equalizing pressure in the middle ear space, which causes a whole host of issues that can compound, also causing hearing loss as well. And the eustachian tube dysfunction is likely due to a variety of different things, both tone and structure. The flattening of the midface that we see in kids with Down syndrome makes the passages more narrow and the structures more narrow in the back of the throat. And the other thing is the eustachian tube. The eustachian tube, this is the ear canal, this is the middle ear space, and this is the eustachian tube that drains back behind the nose. And this drains the middle ear fluid that's made in this middle ear space. And for some reason, the eustachian tube is shaped a little bit differently, is a little bit smaller. The muscles that surround the eustachian tube, as well as the palate, the top of the palate, the tensor veli palatini muscles behind the palate don't work as well because of low tone. So that causes a negative pressure in the middle ear space and a whole host of issues that occur in the middle ear. We see eustachian tube dysfunction in kids with Down syndrome, and it seems to persist a little bit longer than the average child that doesn't have a craniofacial disorder. So usually kids by about 5 or so tend to have less trouble with their ears. Kids with Down syndrome, it's really usually up until the teens that they have trouble with their ears, and sometimes it's a lifelong problem. We see the same thing in patients with cleft palate as well. So the treatment of eustachian tube dysfunction is to monitor the hearing and check the ears. Many times the pediatrician is unable to examine the ears fully because of the narrow ear canals, the cerumen or earwax in the ears. Sometimes the level of cooperation is an issue as well. And so otolaryngologists is your friend in that circumstance, and we're used to dealing with that. And our pediatric otolaryngologists also, or pediatric otolaryngology practitioners, because there's a lot of us nurse practitioners around as well, know how to examine kids, and we have special equipment. We can clean out cerumen and examine them. We also have audiologists that work with us that can monitor the hearing. If there are things that irritate the eustachian tube, which tobacco smoke is one of them, colds and allergies is another one. We want to avoid tobacco smoke. We want to treat any allergies, and we can even do allergy testing that will test to see when we should treat allergies, or if allergy shots or something, or immunotherapy, sublingual immunotherapy that's under the tongue allergy treatment may also be helpful. And then tympanostomy tubes or ear tubes or PE tubes, pressure equalizing tubes. There's a lot of different names for that. These are a surgical technique that you make an incision in the eardrum, place a tube in the eardrum, and that equalizes the pressure between the eustachian tube and the middle ear so fluid does not collect. It helps also in ear infections, helps them present a different way, and sometimes lessens ear infections. And it helps with any of the hearing loss that's associated with middle ear fluid. It's a surgical technique, takes 15 minutes in the operating room, very simple, very easy to recover from. As like any surgery, can certainly have complications. The main complication is sometimes they fall out too soon, and you need another set of tubes. There's no such thing as a permanent tube, but there's longer lasting tubes as well that we use. Let's see, here's tubes, here's about tubes. So they equalize the pressure in the middle ear space. And this is what the little tube looks like in the eardrum. This is a starter tube. This is when you look in with the speculum. Looking down the ear canal here, you can see where it fits in the middle ear space. And these are 3 different types of tubes that usually the first step, the intermediate tube, and the longer lasting tube that we use. And tubes stay in about 6 months to 2 years, fall out on their own. Sometimes they're problematic. There's drainage sometimes when you have tubes. That's always treated with antibiotic ear drops. When they fall out, sometimes we need to replace them. When they fall out, sometimes they leave a hole in the eardrum that might need to be fixed later on. So that's about tubes. And complications of eustachian tube dysfunction are related to pressure in the middle ear space. This is a picture of the eardrum. I tried to put some pictures in here. They might be too advanced for some people, but sometimes people like pictures. And so when we look in the eardrum, we see this little hearing bone here. This is part of the ossicles. And with trouble equalizing pressure in the middle ear space, this causes kind of like a vacuum pulling the eardrum back onto these ossicles. And this is a picture of kind of, it looks like a shrink wrapped hearing bones here. And there's a little bit of fluid down here. Sometimes fluid is yellow in color. But this can cause, long-term, can erode some of these bones. It also, when the eardrum is retracted, it causes difficulty with the eardrum moving. That transmits the hearing to the middle ear and to the inner ear. So we can have hearing loss. It can be temporary if it's just fluid related and retraction related, but if the retraction goes on long enough, it can erode those bones and it can cause permanent hearing loss. Sometimes because of the interventions such as ear tubes, as well as the retraction of the eardrum, we can get a hole in the eardrum. That's a perforation of the eardrum. Sometimes if the retraction is very severe, the eardrum collapses on itself, causing what's called a cholesteatoma. And that's a skin cyst that can grow in the middle ear space and go up in the mastoid bone and can really cause a problem in regards to need for surgery and hearing and those type of things. So hearing loss. Hearing loss is something we see very commonly in kids with Down syndrome. And we know if you're not hearing well, it's going to affect how you speak. Hearing loss is as high as 78%. It was a study that was done, but I would say a great majority of children with Down syndrome related to the challenges with the anatomy and the function of the eustachian tube will have hearing loss. Most of them will have conductive hearing loss, which is the sound going through the ear canal. And we hear when the sound goes through the ear canal and vibrates the eardrum right here, and then moves these little ossicles, which are the middle ear bones, and sends the signal into the inner ear, and then it through the nerves into the brain. So anything related to the middle ear, the ossicles, the eardrum, and fluid is going to cause a conductive hearing loss. Anything in the inner ear is going to cause a nerve hearing loss. So the most common cause of conductive hearing loss in children with Down syndrome, and actually young children as well, is fluid in the middle ear space. And that fluid in the middle ear space is going to muffle the hearing. It's not going to cause deafness, but it's going to muffle the hearing temporarily. In Down syndrome itself, there's probably some abnormalities in the mastoid bone, which is the bone here above the middle ear and surrounding the ossicles. That's the hard bone that's on the side of the head. And it's a little more narrow and probably doesn't have a lot of these mastoid air cells that are fully developed. So it prevents the middle ear from aerating as well. There are some congenital malformations that kids with Down syndrome can have, and those are of the middle ear bones. One is the stapes, which is the stirrup at the end of the ossicles. And then there can be some dehiscence of the facial nerve, which is along the back of the middle ear. There can be some secondary malformations, which we talked about a minute ago, related to eustachian tube dysfunction, erosions of the hearing bone, more specifically, the incus, the malleus, and the superstructure of the stapes. That's the top of the stapes and the hearing bones there. So from chronic eustachian tube dysfunction, we can see damage to the middle ear causing hearing loss. There are some nerve causes of hearing loss as well. And the most common one we see is something called enlarged vestibular aqueducts. I'm really not going to go much into that because that's a whole talk in itself. But there is a small percentage of kids with Down syndrome that have nerve hearing loss, and it's not always conductive hearing loss. So when you're talking to your audiologist or your otolaryngologist, you want to understand what's causing the hearing loss. Is it a middle ear problem or is it an inner ear problem? All right, what can we do about hearing loss? Well, we can treat the eustachian tube dysfunction we talked about with medications and surgery. And then we can also treat the hearing loss. And there's a couple different ways of treating the hearing loss depending upon what kind of hearing loss it is and what your approach is to interventions. Hearing aids, conventional hearing aids are reasonable to do. I saw this one on the internet. I thought this is adorable, little Toy Story hearing aid. But they can be, you know, very, very obvious or a little less obvious depending upon. You definitely, if you want hearing aids, and hearing aids can be fitted if there's mild to moderate to severe hearing loss. If there's profound hearing loss, likely hearing aids are not going to be as beneficial, but we always try hearing aids first. If you're completely deaf in one ear, a hearing aid is likely not going to benefit you. So conventional hearing aids are reasonable to use. Some people use these instead of putting tubes in the ears, just to amplify the hearing, and they work well. There's two different types of hearing aids that we typically use, and this is just conventional in-the-ear hearing aid. And those need to be changed about every 3 to 6 months. The little mold in the ear is because the ear grows pretty rapidly up until kids are about 6 or 7. So when they're babies that are fitted with them, they need to be changed pretty often and fit by a pediatric audiologist that's used to taking care of children, and especially children with special needs. There's something called a conductive hearing aid or bone-anchored hearing aid, and this sits on the bone and sends the signal straight through to the nerve. We do use this many times in kids that, I don't know if you see this little picture, this little boy doesn't have an ear. That's called microtia. But we can use that in very narrow ear canals or kids that have chronic drainage in their ears, and that just bypasses putting the hearing aid in the ear. And then cochlear implant is a whole different type of thing. And I'm not going to go into a lot of that. And that's for profound hearing loss, usually bilateral, though more and more we're doing it for just one-sided profound hearing loss. But conventional hearing aids are a BAHA, or bone-anchored conduction hearing aid with a hearing aid band, is something we use very frequently in young children to amplify the sounds. As far as monitoring the hearing, we monitor hearing at birth, either with what's called an OAE or an ABR. There's much more diagnostic testing if these tests are failed at birth. There's repeat testing and a comprehensive ABR. That's one of the things I do at Hopkins. I run a clinic for babies that fail their hearing screening. And we try to get them in before 3 months of age to do a very specific diagnostic test to see if they have hearing loss and fit them and diagnose that early. And then behavioral testing is sound booth testing done by an audiologist, and that's suggested to be done every 6 months. And then eventually kids will allow the inserts into the ears, and you can get ear-specific information. Young children, you only get global sound field hearing. But as they get older and more cooperative, they can do ear-specific. And once they can do that, yearly testing is suggested, unless the kids are not able to really let you know that they're having trouble hearing. In that case, if there's slushy speech or concerns about hearing at school, then do it more frequently. And then obviously kids that have hearing loss will get more frequent hearing tests. And just to summarize the chronic ear disease, there's a lot of chronic ear problems because there's a lot of recurrent respiratory infections in kids with Down syndrome. And probably the immune system has some impact on that. There's eustachian tube dysfunction that can cause chronic middle ear problems of the eardrum, the fluid in the middle ear, holes in the eardrum and cholesteatomas. And then there can be hearing loss, usually secondary to the chronic ear disease. And then just general recommendations are to have the hearing tested frequently up until 3 years of age and then annually, and then amplify if there is hearing loss that's amenable to hearing aids. That's the ears. All right, let's get to the snot. We're not going to talk about the sinus problems that much because a lot of that's covered in the sleep apnea part of this. So we know kids with Down syndrome have lots of runny noses. And they have lots of trouble breathing through their nose as well. And this is because, again, this narrowing of the midface. And that narrows all the way back to the nasopharynx, or the back of the nose. You have adenoids, which sit at the back of your nose. And those can become enlarged in children between ages 3 and 6 years of age. So between the facial structures and the enlargement of the adenoids, the nose can be very obstructed. That nose being obstructed can cause difficulty breathing through the nose, can cause difficulty of draining of the sinuses. The adenoids themselves can become infected. And then we know the immune system has a little bit to do with all this. So the treatment of all of this, the evaluation, I didn't do a slide about evaluation. It's really symptomatic, mouth breathing, runny nose, and usually it's a chronic thing that occurs, for longer than 10 to 14 days, and sometimes really 3 months. And so there's a lot of tests we can do in the office, but most of the time it's really history. There's scopes, x-rays, and all those things really are not necessary because history is the most important in regards to nasal symptoms. Again, we want to avoid any irritants, which would be tobacco smoke and allergies. We can't avoid colds and viruses. And then lots of saline spray. And the reason we do lots of saline spray is it helps liquefy and clean out that crusting in the nose and keep those nasal passages open because they're tiny. So they get clogged up very, very easily. Now, there's a lot of negotiation around nasal sprays. So some kids can do them. Some kids do better if they do them themselves. And some kids are really unable to do it. Nasal steroid sprays are great because they decrease inflammation in the nose and they're safe to use for kids 2 and above. And they also can help shrink the adenoid tissue in the back of the nose. Allergy medicines are great if there's allergies. And then if none of the medical therapy, I didn't even mention antibiotics. Antibiotics we also do use for short courses or sometimes 21-day courses to treat chronic sinus issues. But more so, we typically would remove the adenoids, which sit behind the nose that obstruct the nose to help with the nasal passages. But we'll talk about snoring because adenoidectomy we don't do all the time as a first-line therapy because we know kids might have sleep apnea, so we evaluate for that first. I'm going to briefly talk about some airway issues, just as an FYI. There's actually plenty of airway issues in kids with Down syndrome. These are dynamic and fixed problems. The first problem that we know for sure is the trachea is smaller in kids with Down syndrome. So it's very important that there's an anesthesiologist or an intensivist that would know how to take care of kids with Down syndrome and know that that trachea is smaller because we would use a smaller endotracheal tube if a child would have surgery or need emergent intubation. We also know there's some dynamic things that happen in the airway. Laryngomalacia is the floppiness of the airway around the voice box. And that's this picture down here. This is kind of a normal voice box with the vocal cords open. This is the epiglottis and this is the arytenoids. And then when you have laryngomalacia, you just have this floppy voice box, where every time you breathe in, all this redundant tissue falls over the voice box, and it causes noisy breathing, typically in babies. And it's typically inspiratory, noisy breathing. It's a symptom we call stridor, which is a high-pitched inspiratory breathing noise. And laryngomalacia is the most common thing. That's diagnosed by an otolaryngologist with a scope that has a camera on the end of it. It's not diagnosed any other way but that way. So you could have stridor, but we don't know if you have laryngomalacia until you've had a scope. Kids with Down syndrome also have floppiness of their upper airway in the bronchial passages that come before the lungs, the trachea, and then the bronchi, the separations into the lungs. So anything malacia just means floppiness. So tracheomalacia is a floppiness of the trachea. Tracheobronchomalacia is a floppiness of both the bronchi and the trachea. And that's because of tone. It's not really understood why, but we know kids sometimes with Down syndrome have a barky cough. They sound like a seal, and that's typically related to that. Subglottic stenosis and tracheal stenosis are fixed lesions, not dynamic lesions. So that's just narrowing. Anything stenosis is narrowing. And I think I put some endoscopic pictures just for fun in here of subglottic stenosis. And this is when you're an anesthesiologist and you're looking into the airway to put a breathing tube down, and you see it's a narrow airway. And this is a grade 1, a grade 2, a grade 3, that's a vocal cords there. It's like a little pinpoint. And grade 4 means you don't have an airway. So these are things that are all important to know in the setting of any anesthesia. I threw in swallowing problems because many times kids with Down syndrome may have some feeding and swallowing problems. There's something we see very rarely, and that's called a laryngeal cleft. And that's a little opening in between the larynx and the esophagus. That food spills out from the esophagus into the larynx. That's also diagnosed in the operating room by looking at the airway. But we know kids with Down syndrome,
I'm reminding you, do PT exercises.
My Alexis is reminding me to do my PT exercises. Thanks. I'm busy. So we know that there's swallowing issues with kids with Down syndrome, and that's probably related to the tone and the coordinating of the swallowing and breathing through the narrow nasal passages. So the American Academy of Pediatrics suggests that all kids that have difficulty with swallowing have swallow studies or evaluation by a speech language pathologist or an otolaryngologist to see what's going on with that swallowing, if it's related to an anatomic thing, a tone, if there's a safe swallow, or if there's a swallow that is not safe. So those are things that we evaluate. That's a talk in itself as well. And the meat of the talk is about sleep apnea. Everybody's interested in sleep apnea. And it's something we see every day in our otolaryngology office. Kids in general snore, and a small percentage of the general population have sleep apnea. There's two patterns of sleep apnea we see in kids, and this is all kids: complete obstructions or partial obstructions. And this is related to as a sleep study. Complete obstructions is exactly what they sound like. Partial obstructions are partial blockages in the airway with a drop in oxygen, or what we call an arousal, meaning the kid wakes up. So those are what more commonly we see in kids are partial obstructions. The etiology of sleep apnea is really anatomic and dynamic. It's really the anatomy and the neuromuscular factors. There is a genetic predisposition to sleep apnea, and there's more specific stuff about Down syndrome. All kids with Down syndrome have increased risk of developing sleep apnea, and a large majority of kids will have sleep apnea. And the reason they have sleep apnea is because of the anatomic issues, because of the narrow midface and the narrow nasopharynx. And we'll go into a few more reasons that I know you guys probably all know as well. And then tone and weight are the other things that we know affect kids with Down syndrome and contribute to sleep apnea. All right, so here's the list. The small upper airway. So there's an airway component, which we already know. And it also the positioning of the tonsils. They tend to sit a little bit more midline in the middle, small nasal passages, a flat midface, and then all the snot that's in there we just talked about, and crusting. Noise that sit behind the nose, and then the tongue, that whether the tongue is larger or have what we call relative macroglossia, or just in position to the jaw and the relationship of the tongue, with the tongue falling back into the back of the oropharynx, which is right where the larynx is in the back of the throat. So large tongue can be an issue, or small jaw causing the tongue to be a little bit crowded. And then the low tone we see that causes collapse within the airways. We know there's a lot of complications of sleep apnea in the general population and kids with Down syndrome equally. There's short-term and long-term issues. There's behavior problems. There can be trouble with glycemic control, hypertension, cardiovascular issues, poor growth, and pulmonary hypertension. I'll talk a little bit more about those. The other complications that we see are related to poor sleep. And poor sleep is a big problem. If your child is not sleeping well, they're going to be tired during the day. And kids, when they're tired during the day, don't always have the same behavior problems that us adults have. And it's usually related to the behavior problems we usually see are inattention, hyperactivity, aggression, poor performance in school, poor socialization, and that does not create a good learning environment. Specifically to Down syndrome, the sleep, there's been studies done on this, the sleep disruption can lead to executive function deficit decreases. And that's very important to know that, you know, if there seems to be, you know, increasing learning problems, difficulties in adjusting to situations, cognitive mood issues, that sleep apnea should be evaluated. How to evaluate sleep apnea. The first thing is your child getting enough sleep? And this sounds like common sense, but we don't think about this many times. Is the child getting enough sleep? Because if you're tired during the day and having behavior problems and not going, you know, getting a small amounts of sleep, it has to do with the amounts of sleep you're getting. And how much is enough sleep? All right, toddlers, they need 12 to 14 hours of sleep. Preschoolers need 11 to 13 hours of sleep. School agers, 11 to 13 hours. Teenagers, 9.5 hours. This is a little graph I have for talks for nurses, which kind of accentuates kind of how the sleep schedule changes over time. We need to look at the sleeping pattern. What time are we going to sleep? What time are we getting up? Are we taking naps during the day? Is there difficulty with falling asleep, or are we falling asleep too easy? Are there distractions in the bedroom? This is a big problem these days with phones, computers, TVs in the bedroom. If we have trouble with sleep, we need to take all of those devices out of the bedroom. And then snoring. Is there snoring? So sleep apnea, the hallmark is snoring and labored breathing at nighttime. Nasal obstruction and mouth breathing is something we see. Parents will commonly describe that they're stretching their neck out, hyperextending their neck. They snore, and have a pause in the breathing at nighttime. They have restless sleep. They toss and turn in their sleep. They sweat. There's bedwetting, and there's things called parasomnia, so sleepwalking, sleep talking, grinding the teeth, night terrors, rhythmic moving. All these things are signs of sleep apnea. There's all kinds of types of kind of questionnaires for sleep apnea, and I just put these up here just for information. All right, and then daytime issues. We know that poor sleep at night can lead to daytime issues. Are they hard to wake up in the morning? Do they fall asleep during the day? Do they fall asleep in the car? Do they have headache in the morning? Do they wake up and immediately want to drink water because their mouth is dry because they've been mouth breathing all night long? Do they have bad breath? Do they have open mouth posture? Do they have hyponasal speech? That's when somebody talks with their nose pinched. So stuffy nose. Stuffy nose, runny nose, and we see in young children inability to gain weight, fussiness, and then we talked about, you know, the poor academic performance and behavior and learning problems. These are another questionnaire. I always have all these questionnaires in here. This is a tool we use. It's called the OSA 18 to score sleep issues. All right. When we look at your kid, what are we looking for? Their weight, what their mouth looks like, what their nasal structures look like, their tone. And then we look at what we call the levels of obstruction. So the nose, the mouth, and the neck is what we're looking at. And then tonsils. And tonsils are the thing that we see as being the biggest problem in most kids with sleep apnea. And interestingly enough, tonsils are the largest between ages 3 and 6 years of age. And then they shrink back by the time kids are adolescents. And that's in some cases, that's not in all cases. These are my patients, and they're big giant tonsils. And the tonsils are those big old golf balls in the back of the throat. So these are some big ones. All right, and that's where the tonsils sit in the back of the throat when they get enlarged. So you can imagine what kind of problem they cause in the back of the throat. All right. When we look at the nose, we've talked about all these type of things. Now let's talk about sleep studies. So sleep studies are done to evaluate for sleep apnea. And they're suggested in all kids with Down syndrome and before TNA. And then we do post-op sleep studies as well if there's issues with severe sleep apnea prior to the tonsillectomy, or if there's persistent symptoms afterwards. I'm not going to go through all this. The sleep study shows us a couple things. It shows us whether there's sleep apnea, if there's periodic leg movement, if there's nocturnal seizures, or there's parasomnias that we talked about a minute ago, or if there's gas exchange issues. Other assessment we can do is, depending upon how severe the sleep apnea is cardiologic assessment, assessment of other levels of obstruction with x-rays to look at adenoids, fluoroscopy, which looks how the trachea and the lungs and the bronchi move under x-ray. MRI or CTs can tell us different levels of collapse. Putting a little scope with a camera in the nose we can do, and there's blood tests. Most of the time we just quite honestly do sleep study. This is just a picture of an x-ray of adenoids. This is what's called a cine and an MRI that looks for different level of obstruction. Has to be done under anesthesia. This is a CAT scan that shows levels of obstruction that are not just related to tonsils. These are all super fancy tests that we can do. This is called sleep endoscopy. We'll do this sometimes to identify whether it's the nose or the back of the tongue or the back of the throat causing the obstruction and the sleep apnea. Having said all that, the most common treatment for sleep apnea. First, we want to identify where the sleep apnea is coming from. Usually in kids, it's tonsils and adenoids. And then is there some other issue that is causing the sleep apnea, like low tone in kids with Down syndrome? There is some medical management we can do if the sleep symptoms of sleep apnea is mild. Weight loss in obese kids. Antibiotics are really not helpful because they're a temporary measure. Allergy medicines we talked about, nasal steroids we talked about, and Singular, which is a leukotriene modifier, we can use to help shrink adenoid tissue and help treat allergies. These are all measures that we can do in mild sleep apnea. CPAP, which is continuous positive pressure machine at nighttime, can be used as well. That's typically not the first line of therapy. That's what we would do if there's persistent sleep apnea after tonsillectomy. There's all kinds of other stuff. I'm not going to go into any of this. These are some friends that have the CPAP machine on. But the most common treatment, and most kids with Down syndrome with sleep apnea will have surgical treatment for their sleep apnea. The most common thing we do is tonsillectomy and adenoidectomy. We know in otherwise healthy kids, the cure rate is about 80%. So kids without Down syndrome, it's about 80%. And they'll get better. And many of the daytime issues are improved. We always do preoperative teaching in kids so they understand what's going on. As far as adenotonsillectomy in kids with Down syndrome, we know at least half of them, but sometimes up to 75% of the kids get better with surgery. And again, that's why we do surgery first, because we know we can help. We can't change all the structures and the tone, but we can remove the obstruction of the tonsils and the adenoids. So we know kids with Down syndrome have improvement in their sleep study. And then we know that the complications are not that different than the general population. And we'll talk about the complications of tonsillectomy. This was just a study that showed symptoms in kids with Down syndrome after surgery, that the kids that were snoring and having pauses in their breathing and restless sleep dramatically got better after surgery. These are kids with Down syndrome. Like any surgery, tonsillectomy has complications. Tonsillectomy is done all through the mouth. You remove the adenoids at the back of the palate and the tonsils in the back of the throat. Requires general anesthesia and a breathing tube. Usually is outpatient for kids with Down syndrome. Usually we keep them what's called 23 hours at least, or sometimes overnight if they have severe sleep apnea. After you have your tonsils out, you have a very bad sore throat. So you don't want to eat. Your snoring becomes a little bit worse. So dehydration, because poor oral intake is common. Very rarely do we see kids coming back in needing IVs. Bleeding is the big risk that we worry most about, and that's related to the scabs in the back of the throat that can peel off. And usually they peel off within 7 to 14 days, but sometimes if they peel too early, there can be bleeding, and it's very apparent. It's blood from the mouth, and it's very scary. All bleeding after tonsillectomy needs to be evaluated in the emergency room, and some kids need to be admitted afterwards. There can be speech problems, and velopharyngeal insufficiency is something we see. That's hypernasal speech, and that's really related to adenoids. Anesthesia complications, airway obstruction after surgery, narrowing of the nasal passages, and we would be very careful to not over-aggressively remove adenoids to cause that problem. Nausea and vomiting and infections are pretty rare, but pain is for sure after tonsillectomy, and pain for 14 days. There are all kinds of other surgical and interventions for sleep apnea if tonsillectomy has been done already. These are just a list of them, and I put some information about hypoglossal nerve stimulator if you're interested in that. U.P.P. is something that's done in adults mostly, but we do it in kids with Down syndrome and cerebral palsy because we know that base of tongue obstruction is a big deal. And that's, again, addressing the level of the obstruction where the sleep apnea is. This is just about the hypoglossal nerve stimulator. This would be something that fails CPAP therapy. And it's a nerve stimulator that has to be implanted, and it helps with the collapse of the airway and kind of tenses up the airway so there's not so much collapse. But it's kind of a newer thing that's been done. There was a case that I found in JAMA of kids with Down syndrome that didn't get better with tonsillectomy and were unable to do CPAP, and there were pretty good results with that. I don't have a lot of experience with that. All right, let's talk a second about guidelines. These are just guidelines in general for the Academy of Pediatrics about screening kids for sleep apnea and the interventions for that. And then there's specific AAP guidelines for Down syndrome that we should discuss symptoms of sleep apnea, including snoring, restless sleep, daytime sleepiness, nighttime awakening, behavior problems, abnormal sleep positions. At all the well checks, we refer to a physician with expertise in sleep, whether that's an otolaryngologist to evaluate for surgical intervention or a pulmonologist, sleep certified pulmonologist to help with sleep symptoms, or a neurodevelopmental person that has an expertise in Down syndrome that can help with sleep issues. And then sleep study, or polysomnograph is the other name for sleep study, in all children by 4 years of age, or certainly sooner if there's symptoms. Just a few things I wanted to mention. When we think about doing surgery in kids with Down syndrome, we know that kids with Down syndrome can have cervical spine abnormalities. So we typically will obtain a cervical flexion extension film to make sure that that is not the case. And the reason being is we wouldn't want to injure the cervical spine at the time of a surgery, especially tonsillectomy, where you bring the head back real far, that we know that we could have them see in orthopedics or keep their head in a neutral position during the time of surgery. Most kids with Down syndrome will have cervical spine films done prior to participation in sports. I wanted to mention again the anesthesia issues with kids. Again, remember they have a smaller trachea and they can have subglottic stenosis, or that narrowing of the area below the vocal cords. We know kids with Down syndrome, because of their tone and sometimes the floppiness of the airway, can have upper airway obstruction after surgery. And that's related to the tone and the mid-face structures and the tongue size, that when you get anesthesia, everything is relaxed. So we want to make sure if there's somebody putting our kids to sleep for procedures, that they know about Down syndrome. They're done in a safe environment, and they're done in a children's hospital where should there be any problems, that those can be addressed, and there's appropriate people to help address those. All right, these are the people I work with. These are my people. This is Dr. Tunkel and Dr. Boss and Dr. Walsh and Dr. Skinner and Dr. Ryan and our PA Elizabeth and Mickey. So this is my team. I'm very lucky to work with such a wonderful team. This is where we work. And oh, by the way, we were #1. Oh, I see a cute little baby there. #1 in the nation, our department in otolaryngology at Hopkins, which was pretty cool this year. And